and DORV. So I'll just ask you some questions from co-op and then some general questions just to see how the classes were and so on. So if you want me to share my video, hold on, where's the video button now? Just type in your questions to all so that everyone can see it. Okay, so first question, it's rainy season and dengue season. So very quickly, what are the cardiac manifestations of dengue? So what do you see in dengue? What are the cardiac manifestations of dengue? Anyone? Cardiac manifestations of dengue. Kavita, let me record. That way I can stop if there's... should I just do it? You just make me the... I can... of dengue. So basically the cardiac manifestations, you can have low ejection fractions. Yes, so they present with shock and the presentation is from low ejection fractions. The function is reduced as well as they can have pericardial effusion. These are the two things you need to look at an echo and see what the function is. And so if the function is poor, then you supportively manage that. On ECG, in fact, they get sinus bradycardia. So instead of tachy, which you expect in dengue, you can have sinus bradycardia as well as ST changes. The good news is that it improves over time. So it's very important to just supportively manage these patients. And over time, the function tends to improve. The bradycardia also improves. And so just giving some oxygen, some inotropes, and just, correcting your platelets and so on, just managing the dengue, all this will improve. Okay, so we'll move on to some questions related to you all with coag last week. So quick question, if you make a diagnosis of coarctation, does it mean you have to intervene? Yes or no? If your diagnosis is coarctation, do you have to intervene? So the answer is not necessarily. The indications for intervention are if you have a blood pressure gradient, so upper limb, lower limb gradient, equal to or greater than 20 millimeters in the cath lab. So that's not a BP gradient just by your arm, but in the cath lab, greater than or equal to 20 millimeters systolic. So let's say you have a patient with a coag and the gradient is 10 millimeters. Then you don't need to intervene. So the indications to intervene are a gradient more than 20, equal to or more than 20 mm in the cath lab, hypertension, or if he's symptomatic. So just a diagnosis of coarctation is not necessarily an indication to intervene, because especially mild coarctation, you don't have to intervene. Okay. I wonder, these are questions based on your two sessions on coag. So please, it's rapid fire if you guys can answer. So the next one, if you have a neonate with a coarctation and he's very sick, he comes into your ICU, his pulses unpalpable, he's acidotic, his perfusion's very poor, what would you do? First thing that you would do. So a neonate with a coarctation who's sick comes into your ICU, 4-day-old. You would give him prostaglandin. Which prostaglandin would you use? Prostaglandin E1, that's right. And what would be your management after that? So once you stabilize him, you start prostaglandin, you stabilize him, would you use surgical therapy or balloon therapy? For a neonate with a coarctation, so you started prostaglandin on. What would be, you think, your best therapy? Surgical or balloon angioplasty? Surgical. So a neonate with a coag, surgical would be the best option because you've got ductal tissue and the ductal tissue tends to constrict again. So some people do balloon angioplasty and then balloon again. But if you do balloon angioplasty, 50% will require re-ballooning. And therefore, surgical option is a better one. So your chance of re-narrowing is maybe 10-15%, much lower. So surgical therapy. So can you name 4 surgical procedures for coag repair? Put them in one line. 4 surgical procedures for coarctation repair. So 4 surgical procedures for coarctation repair. End to end, okay. So end to end anastomosis, yes. Subclavian flap, where you take the subclavian flap and turn it down. Okay, what else? What are the other two? Name 2 other procedures, surgical procedures for coarc repair. So end to end anastomosis, subclavian flap, what else? One more, give me one more. So jump grafts and patch aortoplasty. So if you see here, this is your end to end, the one here on the upper right, where you cut it and attach it. Your one right lower, this one. So this one is end to end right here, okay. This is your subclavian flap. So you cut it here, right? This is your narrowing right here. You cut here, you take the subclavian artery, you turn the subclavian artery down. That is your subclavian flap. This is your patch aortoplasty. So it's for long segments like this, and you put a patch made of Dacron and you actually enlarge the whole area. And the fourth one is your jump graft. So your jump graft goes from ascending to descending aorta. So these are your 4 surgical procedures for coarctation repair. All clear on this? Now, after you've done your coarc repair surgically, which drug would you use post-operatively? For a patient with a coarc repair who comes out, let's say he's hypertensive, which drug would you use post-operatively? Post-operative, which drug after coarc repair, surgical repair? Coarctation, surgical repair, paradoxical hypertension, which is the best drug of choice for paradoxical hypertension in your ICU post-coarc surgical? No, guys. Beta blocker, yes. Which beta blocker? Specifically, which beta blocker? And the answer is not inodilators, mildenone or SNP. It's a specific beta blocker which you will use for post-op surgical, for paradoxical hypertension. Specific, no, not metoprolol, guys. Esmolol. And the reason you see what happens after you do surgical repair, and let's go back to this picture. If you look at all of these, right, you are dissecting along the aorta. And so what lies along the aorta? The sympathetic nervous system. So there's a huge release of the sympathetic nervous system. So you want a drug, a beta blocker, which will suppress your sympathetic nervous system. But you want something that is short acting, that you can turn it on, turn it off. And that's why esmolol is the best drug. Because with any of the others, propranolol, metoprolol, you can't turn it on, turn it off. So let's say you give a beta blocker and your BP goes too low. You want to stop your beta blocker. With esmolol, it's short acting, acts for a few minutes, and therefore esmolol is your drug of choice for post-operative paradoxical hypertension after coarc repair. Now, which drug would you use pre-operatively? So before you send the patient for any of these, especially in older children, not necessarily in neonates, but older children who've got you're sending them for surgical repair, you know they're going to get paradoxical hypertension. Which drug would you use pre-operatively before the coarctation repair? So they put on this drug, they'll be on it for a few days, and then they're taken up for surgery. And that has actually been shown to reduce the incidence of paradoxical hypertension. So which one would you use? Anyone? So with this you can use your beta blockers like propranolol or metoprolol, any of the oral beta blockers. So the goal is to reduce upper extremity hypertension, but you don't want to, make it too low or even normalize it fully, because then you can have inadequate lower body perfusion. So just a low dose of beta blocker prior to surgery to reduce the severity of paradoxical hypertension. Okay, and then after surgery you're going to put them specifically on esmolol. Okay, all clear on this point? Please remember in your pre-op coarcs to put them on a beta blocker, because you'll have much less trouble postoperatively, but not very aggressive beta blocker, huh? You don't want your BP, let's say their BP was 150 by 100, you don't want to make it 100 by 80 because there's still a coag, so you don't want to reduce lower limb blood pressure. You bring it down 120, 130, you're just having it in the system so that whole sympathetic nervous discharge after manipulation is reduced. Okay, all clear on this point? How does balloon angioplasty act? What is the mechanism of balloon angioplasty in coarctation? And is a flap worrisome or no? So what is first question? What is the mechanism of action of a balloon angioplasty in coarctation? What does it do? Intimal tears, right? Intimal and medial tears. Is a flap worrisome? When you see a flap, you see an intimal flap. So it's actually not medial tears. It is mostly intimal tears. You're tearing the intima. Little bit of media, of course. I mean, you can't stop that. You don't want to tear the adventitia because then you're in trouble. Is a flap worrisome? If you see a flap when you do a balloon angioplasty, do you get worried? Yes, no. So, any other answers? Yes or no? Do you get worried if you see an intimal flap? Yes, no. Any other? Take a guess. It's okay. That's the way you learn. It's okay if it's wrong. It doesn't matter. Now you guys have to. So the answer is actually no, and I'll give you the rationale. So if you look here, the way the balloon angioplasty works is it first tears your intima, okay, and then it tears your media. So what happens when you tear your intima and you've torn it, right? So it separates, a bit of it separates out, and that's why you will always see a flap after balloon angioplasty. When you look at the angio, you'll see a little bit of this intima sticking into the vessel wall. You'll always see a flap. Now, a minor flap is when it is less than about 25% of the whole aorta circumference. Major flap is when it is more than 25%. But you must know, yes, so flap is a sign of it means you've torn the intima. What flap tells you is you have torn the intima. So flap is a sign that your balloon angioplasty has worked. If you don't see a flap, that means you haven't torn anything. So flap is not worrisome. You want a flap, and even significant tears will heal. As the arch remodels, they will heal. So in a study looking at IVUS, when they did intravascular ultrasound, 80% had major what we would call dissections or flaps. That means about more than 1/4 of the whole aortic wall had a flap and intimal medial tear, which is fine. So what you have to remember is balloon angioplasty acts by causing intimal and medial tears. This causes a flap. These flaps are seen after angioplasty and are a sign that the angioplasty has happened. And even if you have a major tear, most of them will heal completely or partially with remodeling over time. But because you have this dissection, that's why we say, keep their blood pressure lower after that. You don't go back in, you don't cross the area with a wire. That's one of the reasons you stick the wire across the coag site till you're completely done. You do all your, angiograms and all over the wire. You don't want to cross because now you have a tear there, you have a flap. You don't want your wire going through the flap and dissecting. So, and then within 3 to 6 months, this is completely healed. Okay, all clear on this? Okay, quick spotter, diagnosis, and what material is this made of? So what is the diagnosis? Diagnosis? To uncovered stent for a coarctation, coag stenting, and what is the material of the stent? So iridium, platinum, those are quite expensive. Commonly your uncovered stents are made of what? So it's a juxtaductal coarct or coarctation which is stented. What is the material of the stent, of the common stents that we use, which are uncovered? Commonly stainless steel. So you do have platinum stents, they're more expensive. So stainless steel is a material that works well, body tissue doesn't react against. Yes, stainless steel. Okay. What are the advantages of a coarctation stenting? What are the advantages when you use coarctation stents versus a balloon angioplasty? What are the advantages? So what are the advantages? Okay, no restenosis. It's good for also coarctations that don't respond just to less chance of recoarctation, okay? And less chance of what else? What is the other thing less chance of? Of aneurysms. So there's no restenosis, there's no aneurysm. Remember, in an angioplasty, if your angioplasty is too aggressive and you go into the adventitia, you may get an aneurysm formation. So coarctation, you're supporting the wall, you don't get aneurysms, no restenosis, and it's very good for long segment narrowing, where you have tubular narrowing. So for instance, if you have a coarctation that looks like this is your coarct, and then you're getting a long segment, right? You can't use balloon angioplasty in this. Your option is you can use a patch surgical with a patch aortoplasty, or you can do a stent. A big advantage of a stent is you can re-expand it at a later stage after growth is completed. So no restenosis, no aneurysm, good for tubular narrowing, can be re-expanded at a later stage. Okay, so rapid fire. Which intervention? Subclavian flap is done in which age group? Subclavian flap, which age group? Subclavian flap surgery, which age group? I should have warned you guys, I'm going to do a quiz on your two last classes. In neonates. Yes, in neonates, because you cannot do it in older kids because you're using the subclavian artery. So in neonates, they can at least form collaterals if you use their subclavian artery. In an older child or an adult, if you're going to go use their subclavian, what will happen? They can get gangrene of the arm. They will have acute ischemia of the arm. So you cannot use it in older children or adults, so only neonates. Long segment coarctation, what are your options? Long segment coarctation, what are your options? Name a few options. So end to end will not work with long segment. So patch aortoplasty or a jump graft, or what we just said, a stent, right? So long segment coarctation you can consider stent, or surgically you can consider patch aortoplasty or jump graft. Generally end to end is very hard because there's a long segment. So from here to here you have to bring it together. It becomes quite, you don't, it's not, remember that the spinal arteries, the intercostal arteries, all attached to the aorta. So you cannot, let's say you have a 4 centimeter gap. You can't bring that together always because you've got all these things, nerves, everything attached to the aorta. So generally long segment will be patch aortoplasty or jump graft or stent. 3-year-old with discrete coarctation, what would you consider doing? So balloon dilation is fine, or an end-to-end is okay, but balloon, in today's day and age, balloon angioplasty would be your method of choice. Treatment of newborn with coarctation, what would you do? So surgery for prostaglandins and surgery. Treatment of recurrent coarctation, that means you've done the repair and now it comes back. So what are your options? So balloon angioplasty or stent. So recurrent coarctation, balloon angioplasty or stent in an older child, adult is well accepted. Newborn or native, what we call native coarcts, some people will do surgery, some will do angioplasty. But definitely recurrent coag, everybody would go for angioplasty because you've got so much scar tissue that surgery actually becomes quite difficult. Okay, so that's a little revision on coarctation. Move on to a couple of random questions before I let you go and do your Thursday work. So what are can name a few conditions which cause a wide split second half sound in cyanotic heart disease? So you know wide split second half sound, acyanotic heart disease is ASD, atrial septal defect. But can you name a wide split second half sound in cyanotic heart disease? What type of TAPVC would that be in? Which type of TAPVC? So not, well, I didn't mean in location, in generally non-obstructed TAPVC, right? In any TAPVC which is not obstructed, it could be cardiac or supracardiac, but when it's non-obstructed, yes, it acts like an ASD, similar, except that there is all the blood going to the right atrium and they're blue. Any other lesion? Wide split second half sound, cyanosis. So non-obstructed TAPVC is one, and you've got to also think of common atrium. So common atrium is like an ASD, so you'll have a wide split second half sound, but there's a lot of mixing of systemic and venous blood, pulmonary and systemic venous blood, so you'll be desaturated. Plus they can have left F3C to left atrium, they can have systemic venous abnormalities, so that's why you can get a wide split second half sound along with cyanosis. Now unroot CS would, if it's only isolated unroot CS, then it acts like an ASD. So it acts like what we call as the unroot CS basically acts as your what I call coronary sinus ASD kind of. So when you've got, for instance, say you have your atrial septum is intact, right? And this is your left FCC, let's say, coming in here into the LA. And it's entering here into right atrium, right? It's got its right atrial opening. Now in isolated unroot, which means that this wall is absent, right? This wall is absent. What happens is LA pressure is still higher than RA, right? So typically what happens, the blood will go through this and into the RA. So it will act like an ASD. There will be still pink blood going to RA. So there will still be pink. And it will be it's one form of a ASD where your interatrial septum actually is intact, but they've got an ASD. So it's a good thing to remember when you've got clinical features of an ASD and yet your interatrial septum is looking intact, you should think of an unroot CS or what we call a coronary sinus ASD. Okay, but if they're blue, now remember you can get unroot CS with common atrium, and that's one of the associated like systemic venous anomalies. So it's something you should look for when you have common atrium. But they will be blue basically because of the common atrium, you've got all the mixing going on. Okay, all clear on this? Next question, diagnosis. X-ray spotter. So a supracardiac TAPVC. Yes. Now, this is your snowman appearance, right? So tell me what forms the head of the snowman. So the snowman, what forms the head, what forms the body? So what forms the head? So the ascending vertical vein, denominate and dilated SVC, good, that forms the head. And what forms the body? What forms the body? The rest of the heart. So if you see here, this is going to be your SVC, this is your innominate vessel, and then this is going to be your vertical vein. So this is your head, and then this is your rest of the heart, which is your body. Okay, so that's your figure of 8 sign or your snowman sign. Okay, good. Now next question, what is the diagnosis here? This is an echo, 4-chamber view. What is the diagnosis? You can see it here in the frozen frame as well. Diagnosis? What is that? Anything else? Anything else which will be like this attached to the mitral valve? Your supramitral ring, yes, or a supramitral membrane. And you can see, everyone see that? You can see this thing attached to the mitral valve, right? So, and you see the LA is dilated. So this is a supramitral membrane or a supramitral ring. So next question is, how do you differentiate a triatriatum from a supramitral membrane? Because you see, when you saw it, it could be a triatriatum, it could be a supramitral membrane, right? How do you differentiate these two on echo? What is the difference? How do you differentiate triatriatum and supramitral membrane? Supramitral membrane is distant to PFO. Relation. So it's not really related to PFO, it is related to the relationship with the left atrial appendage. So supramitral ring is below LA appendage. Tell me, is that right? Everyone agree? Yes. So let's draw this. Let me draw this for you. Okay. So what happens is, this is your left atrium, right? So this is going to be your appendage somewhere here, let's say, right? This is your mitral valve somewhere. Wait, I do that appendage wrong. This is your mitral valve, right? Okay. This is your membrane, typically here. This is your triatriatum, right? So this is called the upper chamber. This is your lower chamber. So in triatriatum, this appendage will always be linked with the lower chamber. In supramitral membrane, it's too low. So the appendage will always be above it. Understood? Let me draw that again to be clearer. So this is your mitral valve here, right? So this is your supramitral membrane here. This is your triatrium here. Let's say your appendage is somewhere here. So if you see here, we'll always have in triatriatum, your appendage will be below, it will be in the lower chamber. In supramitral membrane, the membrane will be below the appendage, or you can say the appendage will be above the supramitral membrane and below the triatriatum. Okay. Of course, you can also make out by location. Generally, supramitral membranes will be more attached, very close to the mitral valve. Triatriatums tend to be a little more distal, a little higher up. They're more in the body of the LA. Yes, so supramitral rings are adherent to the mitral valve, whereas triatriatums are within the body. Okay, all clear on this? Now this is a CT diagnosis. Spotter. And I want you all, I hope you've all been spending time in CT, because as CT cardiologists now more and more we need to be able to recognize CT images. So this is the spotter. What is that? What is the diagnosis? Anyone? Bonus question. Okay. So if you look here, this is actually your aorta, right? This is your RV. So this is your RV, this is your thing, and that's your aorta. Now look at it carefully. It's like just like this. So this is actually a unicuspid aortic valve. This is how a unicuspid is attached at one side. You see it's got one attachment and then it's just open. So this is a unicuspid, unicommissural aortic valve. Prognosis is quite poor with balloon angioplasty in unicuspid valves. Okay, this is a quick repetition. I'm going to do this every time till you all get it right. What is the first one? On the left, the type of AV canal. First one on the left, complete AV canal. Okay, next one. Second one, intermediate. Third one, is transitional. And the fourth one is your partial. So the one that looks like partial but has a ventricular component is called your transitional. Right? The one that looks like partial but has a ventricular component is your transitional AV canal. Your intermediate looks like it has a large ventricular component, but it looks like it has two AV valves almost. It doesn't have that complete AV valve. It has two AV valve rings. Okay, all clear? And I'm going to go over one more slide, which you guys always get confused. So classification of pH, mild, moderate, and severe. What is mild? Let's go by systolic pressure. Systolic pressure, how much is mild pH? Systolic pressure, how much is mild? Up to how much? Okay, and what is moderate? Moderate is, okay, so I want you, so 50 to 69, and severe is greater than 70. So please take a picture of this slide. This is Dr. Anita Saxena V class from All India Institute, and keep this on your phone so you remember this. So, systolic, look at the second one, the systolic pH pressure. Don't look at the mean because you get a little confused right now. Choose one. So your systolic pH pressure, mild 25 to 50, moderate 50 to 69, severe is 70 and above. And if you look by RV pressure, up to 50% systemic is mild, 50 to 66% is moderate, and more than 2/3 systemic is severe. Okay, all clear? Take the picture on your smartphone and save it and keep looking at it. Okay, now until which Heath and Edwards stage is pulmonary resistance still reversible? So 1, 2, 3, 4, 5, 6 until stage 3, it is reversible. That's right. Quickly, stage 1, medial hypertrophy, which is reversible. Grade 2, intimal hyperplasia, reversible. So grade 1 is when you get medial hypertrophy, is when you get a lot of this pulmonary vascular reactivity and crisis. Grade 2, intimal hyperplasia, and grade 3 is some lumen occlusion from intimal hyperplasia, still reversible. Grade 4, arterial dilation, by this time it's irreversible. So what happens when the arterioles now are narrowed? The arterial starts dilating up. Grade 5, angiomatoid formation. Grade 6, fibrinoid necrosis. So till grade 3, they are reversible. Okay, what is your diagnosis? Diagnosis. This is a fluoroscopy being done. This prosthetic valve. Is it a tilting disc or is it something else? You see two leaflets, right? Two leaflets opening. So bileaflet. And is it mitral or is it aortic? Mitral or aortic? The bileaflet mitral valve. So what is commonly a bileaflet mitral valve? Which type of valve? Which type of prosthetic valve? So you can see the same gauge. You see this is the ring, and then you see the leaflet. Okay, good. Now it is mitral because if you see you're in LAO and then it's closer to the spine. So that means it's posterior. It's not an aortic valve. Now, what is your intensity of anticoagulation? What INR would you use in a mitral valve versus an aortic valve? So what INR do you want in an MDR? So in this patient, what INR would you want? What INR? So, okay, in AVR, MVR. Okay, in AVR you're saying? Okay, answer one. In NVR, which INR do you want? In NVR, which one? 2.5 to 3. And AVR would be lower. So aortic is 2 to 3. MVR is 2.5 to 3.5. Average is 3, right? But remember, in mitral valves, you needed more anticoagulated. You could even go up to 3.5 because it's a low pressure system, right, from LA to LV. And so you need higher anticoagulation. In aortic valve, the LV is pumping. You can push out, you've got better flow through that aortic valve. Therefore, 2 to 3 is okay. If you use a bioprosthetic valve, then you can use aspirin 80 to 100 mg per day for aortic valve for 3 months. Some people use warfarin and have an IRR of 2 to 3. And mitral, again you can use aspirin or you can use warfarin, and again you keep INR around 2.5 for 3 months. Typically we use for bioprosthetic valve, aspirin is fine for 3 months. Okay. Diagnosis. Diagnosis. The 4-chamber view. And what are you seeing around it? A large. What's the diagnosis? A large. What happened? Everyone fell asleep. A large pericardial effusion. So can you name some causes of pericardial effusion? Yes, a large pericardial effusion. Name some effusion. Name some causes of large pericardial effusions. So this is, something you need to guess. So viral infections, Wessler's post-surgery, myocarditis, okay, yes. Tumors, connective tissues like SLE, you need to remember lupus. So there's a long list. So viral infections like Coxsackie, echovirus, autoimmune like lupus, post-pericardotomy syndromes like Postop or post-trauma. Remember tumors like intrapericardial tumors. And then, of course, if you have a lot of strands and so on, bacterial infections, staph. But also remember in our country, tuberculosis. Okay, diagnosis. See this thing along the anterior leaflet of the mitral valve. And then along the aortic annulus. What is that? You see that echogenic, a very echo bright anterior leaflet. Anyone? Is it unusual? I'll show you some common and some uncommon, but just something you think about if ever you see. What is that? So this is a intracardiac calcification. Not commonly seen, but again something you should keep in mind. Run your scale, change your scale, look in other views. Sometimes you get reflections in one view. Make sure it's reproducible. But this is something that is seen in pseudo-hypoparathyroidism, basically wherever you have a lot of calcium, end-stage renal disease, and also in these things, endomyocardial fibrosis, and a weird genetic thing called pseudoxanthoma elasticum. So something just to keep in mind. Okay, you're going to be doing TGA. You did one thing of TGA and you're going to have TGA. So quickly, is this a regressed LV or a non-regressed LV? This is a transposition of the great arteries. Would you call this LV regressed or non-regressed? You see the LV long axis view. So this is non-regressed. Why? Because look at the posterior wall. It's nice and thick. More easily, look at your, when you want to just assess, right? Because I'm just showing you a spotter. From here to here is how much on the marker? 1 mark to 1 mark is how much on the echoes? That is 10 what? 10 millimeters, 1 centimeter. So look at your posterior wall. If I took from here to here, it's easily at least definitely more than 5-6 millimeters, right? So you've got a good thick posterior wall. And you look at your LV, it's not collapsing or banana shape, right? You've got a good, fairly, got quite a good amount of volume even in systole and diastole. So this is a non-regressed LV. It should be suitable for an arterial slit. So I shall end with that, and